Welcome to Ask Dr. Mia podcast. Today I have Dr. Kristin Beavers with me. Kristen is a colleague of mine within Geriatrics, Department of Internal Medicine at Wake Forest School of Medicine. She is a professor and has gotten her PhD and a nutrition degree at Baylor University in Texas. And she actually has been here for a long time and have been doing a lot of work in the study of nutrition, exercise, mitigating loss of bone and strength training in people who undergo intentional weight loss. So knowing Kristen's background, I think you get an idea of what we're going to talk about today, which is really weight loss and bone loss and how to strengthen our bones, even if we're either intentionally or unintentionally losing weight. So welcome to the podcast, Kristen.
Thank you. Happy to be here.
Thanks. And I'm starting out this season by asking people kind of what kind of caregiving experience that they have in their real life. I know you have 2 kids of your own.
Yes, right. So I have 2 lovely children. Maddie is 13 years old, so she's in middle school, and then my son Owen is 9, so he is in elementary school right now. So that's my primary caregiving responsibility. I would say, as related to this topic, my mom was visiting us a few years ago when she unfortunately had broken her ankle and foot, actually attending a sporting event for one of my children. It was sort of just like happened to be walking and hit an area where the pavement was uneven and anyway, the importance of what I study came in laser-like focus, like when you have trouble ambulating, and every step matters, you pay attention to things like how far is it to the toilet? How far, how many stairs are in my house? Things of that nature. So, I certainly can't relate to all the aspects of caregiving for aging parents just yet, but I've had and some exposure to it.
Yeah, absolutely. And speaking of mothers, my mother and her mother, my maternal grandmother, have all had osteoporosis.
Mm-hmm.
In fact, my grandmother's osteoporosis was quite severe, where she would, any little injury, like falling from a seated position that was very low on the floor, she would break a bone. And it was devastating toward the end because it really limited her function, and she was kind of confined to her bed, which is kind of an extreme scenario.
Yeah.
And that osteoporosis treatment in China is still perhaps not as widespread as here, and they were non-compliant in their own way about taking medication. So very excited to talk with you today about bone and weight. So I guess to start out with, what do we know about weight loss and bone loss in general? Do we automatically lose bone every time we lose weight?
Yeah, I mean, that's a great place to start. I would say, when people generally, the quick answer is likely yes. Especially in most cases of caloric restriction, so dietary type weight loss. So, people say they want to lose weight, they want to lose fat, but some of what you lose does come from the musculoskeletal system. There have been many studies over the years that would suggest that if people lose, 10% of their weight, which would be a reasonable target for like a lifestyle intervention, I think most dietitians would say that would be a successful intervention. You're looking to lose about 1 to 4% of your bone, depending on the site. So weight bearing, the hip is the area that, when you think about fracture, that's an area that we watch a lot because those types of fractures can really be life changing, maybe even life ending. And so at that specific site, you're looking at maybe like 2% loss, accompanying about a 10% weight loss intervention.
That seems like a lot of bone to me because, yeah.
Well, it varies. I mean, I will say, just to put that into context for you, bariatric surgery, which is another area that I study, these folks lose a lot of weight and they also lose a lot of bone. And those types of interventions where success might be like losing, 30% of their weight in the same time frame as a lifestyle weight intervention, you're looking at maybe 10% bone loss. It does vary based on the surgery type, but I'm just saying the general rule of thumb is the more weight you lose, the more of that would be bone.
Wow. I don't think I fully realized the implication between weight and bone, but that makes sense because when we lose weight, the amount of pressure and stress on our bones also decreases. And so our bone doesn't need to work as hard to lift the same amount
That's
of
right.
body.
Right. And I mean, I think in that, right, that's exactly right. That's something like Wolff's Law. So your bones do respond to the stresses they're placed under. And so you might think, and I mean, that, if you're losing weight, that you would lose bone and that would be adaptive. But we know from a large body of observational data that when older adults lose weight, they also tend to fracture more. And that's the reason we think it's worth intervening upon to try to mitigate the bone loss if we can.
Gotcha. And so in order to check for bone loss, I know I routinely recommend my patients to get a DEXA scan. I know it's not done as often as one should. Can you just tell us what is a DEXA? What are they measuring?
So DEXA stands for dual X-ray or dual energy X-ray absorptiometry. So it is a bioimaging tool. It is a scanner that basically emits two X-rays. So that's the dual energy X-ray part. And one of these X-rays is has a I'm trying to think of ways, but has a 10. It's stopped by bone. One of the X-rays is actually stopped by fat. And so what you get after having one of these scans done, and you could do it of your whole body, you can do it at regions. So again, the hip is a particularly important region from a kind of a bone assessment standpoint, as is the spine. It gives you actually kind of a very pretty picture, like a sophisticated X-ray of what your body components look like. And so from this tool, you can get things like your bone density, you can get your fat mass. Kind of honestly, dirty secret to DEXA is that the leftover ends up being quantified as lean mass, and so it is used pretty routinely to measure lean mass. But just know that when people say that, they're thinking it's muscle, and it does map onto muscle some, but it's also water weight, it's also connective tissue. It's more than that. I think what DEXA is really good at is measuring fat and bone. And so for the purpose of this talk and for osteoporosis, it is kind of clinically how bone health is monitored. So with a DEXA scan, and the bone images that are typically obtained, again, at the hip and spine, usually, sometimes the forearm if you can't get one of those sites, is compared to what a young adult reference standard would be. And kind of based on that comparison and where you fall in relation to the young adult standard, folks can quantify, or doctors can kind of put you in different bins of either normal bone density, low bone density, or osteoporosis.
And do we know if there are any race or gender differences in terms of what a healthy bone amount is like?
Yeah, it certainly does vary. But the young adult standard tends to be a young white woman. I mean, that tends to be the comparison. But there are definitely different reference groups that can be used.
Gotcha. Okay. All right. So after, say, people get a DEXA scan, or now I know there's actually two X-rays, not just one, one to look at bone and one to look at fat. You get a report, and I see those reports. They kind of start at 0, but then go down to -2. And if people are having -2, then that usually puts them into an osteoporosis category. And anywhere in between -1 and -2 is usually what's called osteopenia, meaning there's some loss of density in the bone, but not to the point of osteoporosis.
Yes, and it's -2.5, but yes, that is absolutely right.
2.5.
Yeah,
Sorry.
yeah, you got it. Nope, that's right.
Okay, great. So in terms of bone density, I know sometimes a lot of my patients also have had back surgery, and so their lumbar spine is not a good measure. But you're saying people could use their forearm, their hip to compare.
Yeah, and usually, I mean, osteoporosis, or is a systemic disorder. So if you have it at one site, the assumption is it's elsewhere. And so, if you can't measure the spine for the reasons you cite, and actually personally, in the work that I do, the spine ends up being a kind of problematic. I mean, it is hard to interpret because well, I'm interested in weight loss. And sometimes when you have if you have someone, let's say, that's losing weight and they have major shifts in tissue in their abdomen, I mean, that's where people tend to maybe lose some weight, that can affect the reading of DEXA. Also, typically we think, and it's not wrong, but that the more dense your bones are, that, the like less likely you are to fracture. But if you have compression fractures at the spine, let's say, that can, or if you have osteophytes, so if you have kind of arthritis at the spine, that can artificially make your bones look more dense. And the spine, I think, is particularly susceptible to that, maybe more so than the hip. So anyway, this is all to say, yes, if you can't do the spine for whatever reason, the other site that people will typically do is your distal radius. And so, but even if you couldn't do the spine, you could just do the hip. I mean, clinicians could use that information.
Yeah, and distal radius for us for the medical audience is wrist. Yes,
that's right. Your wrist. Sorry about that.
No, you're totally fine. You're living in the bone world, so this just comes easily to you.
Yeah.
And in general, according to the U.S. Preventive Task Force for women older than 65, that's usually when we start recommending screening for osteoporosis. And sometimes we do screen for people who are younger, but at a higher risk for osteoporosis fractures. Like, for example, if they have been taking steroids for a long time, or that they maybe have undergone a major weight loss surgery, like what you had mentioned before for gastric bypass, or have had eating disorders, things that have maybe prevented the absorption of calcium and vitamin D, that puts them at a higher risk for osteoporosis. They can potentially be screened sooner.
Yeah.
Great. Well, transitioning a little bit, because I know we have heard a lot of news about some of these new diabetes medications, GLP-1 inhibitors. What do we know about these new drugs besides the fact that they reduce blood sugar?
Yeah, man, this field has just exploded for sure. And it's exciting. I mean, it really is. Yeah, these medications, these incretin mimetics in particular, the GLP-1 receptor agonists, the Wegovy's, the Mounjaros, things like that. As you mentioned, were originally kind of approved for diabetes and for hypoglycemia, so managing blood sugar and things like that. And people recognized that people were also losing weight on them. And so the field started moving then to thinking about using these medications more for a chronic weight management standpoint. And they are very effective at inducing weight loss. I mean, I think the typical weight loss for, and I mean, honestly, every day I feel like there's a new drug in the pipeline, there's a whatever, but, you'd be looking at, annually, maybe 15% weight loss on some of the earlier generations, maybe up to weight losses rivaling bariatric surgery with some of the multi-agonists. I mean, like, this is, it is definitely a brave new world in terms of, obesity management with these medications. So, in terms of what we know about bone loss, the field is emerging. For sure. And, studying bone takes time. I will just say, I mean, typically just bone remodeling takes time. So you're looking at least, I would say, to feel pretty confident, year-long interventions, to see changes in bone that might exceed, just what an error on the machine would be, something like that, to really feel confident in it. So anyway, this is just simply to say the evidence base is emerging in this area. There are data from what are called preclinical studies. So these might be like cells or animals or things of that nature that actually suggest these medications are good for bone. So they increase bone formation, decrease bone resorption. Like, there is a body of data that kind of would suggest mechanistically that they have that effect. The data I've seen in people, again, limited as it is, does suggest that, like with other weight loss modalities, if these medications induce significant weight loss, which again, depending on the dose and how long you're on, they really can, likely you're going to experience bone loss. And so I think that that's just something to be aware of and, be, just monitoring. Maybe something, there was a big study that actually got, an FDA approval for major cardiovascular risk reduction with one of the weight loss medications, and resulted in the insert for the medication, sort of just noting that among older adults and women who were taking the medication, that there was a trend for increased risk of fracture. And so, these are emerging. I mean, I think it just, to me, it's based on, reasoning by analogy, what we know about other weight loss modalities that typically cause bone loss. I think it's reasonable to think that these would. I mean, that it could be different, but likely if they're causing significant weight loss, some of what you're losing is bone. And then thinking about how, what the risk benefit there is probably something, at least to be mindful of.
Right. Yeah. So it sounds like it's still a little too early to tell exactly whether they make you lose bone or potentially neutral or potentially help you gain a little bit of bone. So, okay, well, that's good to know. And I know that for these drugs, they basically, simulate a natural protein that we have in the body, and that they basically prolong the time that food stays in the stomach so that it takes us longer to digest them, and that makes us feel full sooner so that we don't eat as much. And there are so many different ones. I can barely keep track of the brand name versus the generic name.
Right.
And which one. I mean, I think we hear about Ozempic a lot. That's one. Wegovy is another one that we hear. These just are names on the commercials. But which one did you say was the one that seemed to have benefit for heart as well?
So Wegovy, the semaglutide 2.4 was the one. There's a big study called Select that showed that people who were taking this medication also saw a reduction in MACE, major adverse cardiovascular events. And so the FDA approved it for that indication, which I think is really important for older adults because they, could be taking it for that reason beyond the weight loss,
Yeah. I'm still dealing with a lot of insurance authorization for these medications for people who don't have a diagnosis of diabetes, and maybe they do really want to lose weight by going on these drugs. It's pretty difficult, at least in my experience thus far, in terms of getting them approved. There may be other folks who are better at it than I am, but certainly that's been my experience so far.
Yeah.
No, you go ahead.
Oh, I was just going to say, and I think that just brings up, another thing to be thinking about with these medications. I mean, they appear to be, highly effective as long as you can access them and are on them. And so, and with many other weight loss approaches, it does seem like, when these medications stop, that weight regain is likely to happen. And so, I mean, that, I think if, there are barriers to access issues, that is something important to think about,
Right. And when it comes to, say, someone has already lost a lot of weight, and that you assume they probably have weak bone, either from that weight loss alone or because of their other risk factors, what can someone do to improve their bone health?
So we've been studying this for a while. Like, what could you maybe add to weight loss to try to mitigate the bone loss? You maximize the fat, improve the cardiometabolic stuff, but spare the musculoskeletal system. And certainly exercise is something that, that has been shown, especially weight-bearing exercise or a loading-based exercise. So if you can load your bones, and again, progressive resistance training, so going to the gym and using, weight machines, or certainly free weights, or, even TheraBands can do it. Although I will say sometimes it's hard to, your bone, you have to stimulate it. And so it does depend on the intensity of what you're doing. I mean, I'll just say that. So sometimes home-based exercises are a little bit harder to kind of reach the intensity that you need to actually build bone. But exercise can be effective. And again, I think especially if it has some type of loading component to it.
Well, what do you mean by loading?
So when you think about like exercise prescriptions, like there are kind of, I mean, there's several tracks, but like you think about like an aerobic track. So like kind of walking, maybe swimming, biking, but these things aren't really pulling on the bone in the way like you might like grab it, like loading, like jumping, or what would be another example? Like wearing a weighted vest, maybe while you're walking, could like load yourself while you're walking. Or certainly, if you're lifting weights, I mean, that's sort of your your muscles are kind of, they're attached to your skeleton, right? So there's pulling on your skeleton as you're doing that. So like anything that would kind of compress the bone, either gravitate, either loading, like taking advantage of gravitational loading, or muscle contractions will stimulate the bone, versus something again more like swimming, which does, like you're in the water, it's very buoyant, you're not really, it's great. I mean, there are benefits to swimming or cycling cardiovascularly, but it's not really affecting this, loading the skeleton and where you might expect it to respond. Because again, going back to something we talked about before, your skeleton will respond to the loads placed on it. And so if if you want to offset weight loss associated bone loss, you probably, one way to do it would be to load it some other way. And exercises, depending on the type, is one other way.
Interesting. Yeah. So I wonder, there are, sometimes people think about what type of exercises are good for people with arthritis. I think those are probably the type of exercises that load on the bone, because, we generally encourage people with arthritis to do water aerobics or swim because there's lower pressure on the bone. But I guess it's harder for the bone to see. It's good for your heart, but maybe not the same way as running.
This is a tried and true kind of tenet of exercise physiology. Like there's a specificity to the training. It does depend on what you're doing in terms of the outcome you're getting, and probably why in large part, like when you think about the national guidelines for exercise, it recommends an aerobic and a strengthening component, right? So you can kind of see the entire benefits on the entire body system.
Yeah. I have to say, I am much worse at the strength training part compared to the aerobic part. Yeah,
it is. Yeah. I definitely need. I will run. I mean, I don't know. I do it as much for my mind, honestly, as my body. But I will do that every day. Like that's not even a thing. I don't like. I just like to get outside. But like, I need someone to be
coaching me.
Yeah, like I mean, telling me to do this to lift weights.
Yeah, no, lifting weights is hard, and maybe a little bit less familiar than other exercises.
It can be intimidating.
Yeah. So for people who do say put on hold on to handheld weights while they're walking, or putting on a weighted vest, so the potential benefit is that you could be strengthening your bones while doing an exercise. Okay.
Yeah. And we found, we actually just kind of wrapped up. I mean, it's still not prime time yet, but had done a large study funded by the National Institute on Aging, thinking if you could use a weighted vest sort of as this, as a stimulus to offset bone loss happens when people lose weight. And so, and kind of the premise behind that, again, as we said, is that one of the reasons that you're losing bone when you lose weight is you're unloading yourself. Well, we'll load you back. And so we'll do it by using a weighted vest. And another reason that we chose the specific, the weighted vest as the kind of tool here is because we know for older adults, and this study was conducted in older adults, getting them to walk is, I'm not saying it's easy, but that's a different lift than getting them to go to the gym. And quite honestly, that study was launched during COVID. And I just really did not appreciate like this. You could wear the vest anywhere. Getting people back into gyms during that time was really hard. And I think it just does speak to there are access issues. Older adults would have to, go to a gym, and, depending on where they live, that may be hard. Ideally for that group, you would have, some type of safety supervision, whereas the vest sort of circumvents some of that, because you can really kind of do it around your neighborhood, around your house, something like that.
Gotcha. Well, I know your results are coming out soon, and we will eagerly await to see whether the weighted vest helps with reducing bone loss while exercising. But transitioning a little bit to talk about foods, or what type of diet that can help us build bone.
Yes. So, and I'm a registered dietitian by training. So this is low hanging fruit, I guess, for me to think about. So when you think about nutrients that are really beneficial to the musculoskeletal system, the top three that come to my mind are protein, calcium, and vitamin D, because we just know that they're important. They're important for lots of aspects of health, but they're certainly skeletal health. So from a weight loss standpoint, I would say across the board, problem with weight loss is that you are less likely to take in the adequate amounts of these nutrients. So it might not be that you need to have excess. It just might mean that you shouldn't be deficient. Do you know what I mean? And that can be hard to do when you're reducing your calories. I mean, so sometimes, supplements can be really helpful in that way to meet the recommended dietary allotment for these nutrients. But I would say, we've done some work, and I have some colleagues, a lovely mentor who's done some work looking at calcium and vitamin D. It does seem like with those nutrients that you want to make sure that you are sufficient. Maybe super dosing. I don't know if that's right, but it's worth noting that your calcium absorption goes down when you are when you're losing weight. It just does, and so you might need to take more just to absorb more. But generally speaking, meeting the recommended daily allowance for those ones is okay. Protein, it does seem like if you can go a bit above what is recommended. So right now, what people recommend typically is about 0.8 grams of protein per kilogram of body weight, which I know is kind of frustrating, but you could kind of do the math and figure out where you would stand, based on your weight. And if you can get that closer to 1, even 1.2, that probably is going to help offset not only bone, but also muscle loss that happens with weight loss, to preserve those tissues.
So for an average person who, I don't know, 150, 160 pounds, that is what, 75 kilos?
That's right.
And so you said 0.8?
That's what the RDA is. But if you think if like 1 is what you'd want, if you're 75, you'd want about 75 grams of protein per day. And spread out kind of throughout the day is sort of that's the other kind of trick with that. So your body can only absorb so much at one time. And people tend to be pretty good at getting like their adequate levels of protein during the evening meals. Like that tends to be breakfast is one that sort of gets, that. So I think if you can, from a practical standpoint, you would just be intentional about thinking about including protein during breakfast. Or throughout the day as snacks. But again, this is why this is hard to do. I mean, it's hard to do maybe if you're not really paying attention to it, and then putting yourself in a state where you're reducing your calories. I mean, then it's, then I think you need to be even more intentional about where those calories are coming from.
Right. And how do you know, like, how much calcium is, say, too much versus not enough? What are some equivalents in terms of, I don't know, a yogurt? How much calcium is in that versus? Because in general, I don't typically recommend for people to take calcium supplements because I find that they can certainly have some constipation associated with them, and that I'd rather for them to eat yogurt, cheese, milk, that kind of thing. But there are other ways of getting calcium. Right.
For sure. I mean, even like I think that we sneak it in orange juice. Like orange juice is fortified with this because, and so that's the way to do it. Certainly, I mean, it is calcium is in leafy green vegetables. It's just our ability to absorb it is a little bit impaired, but not impossible. And so I think especially just recalling some of my early kind of nutrition knowledge. I think even if you can cook greens in some type of acid environment, which maybe sounds crazy, but like that's what a stir fry is, or that's like, that can liberate some of that, the calcium that's in the greens. And so you can absorb it better. So yeah, there are certainly ways to do it. But again, I mean, I hear what you're saying, but multivitamins are also a way to, kind of hedge your bets. So maybe not doing, anyway, yeah, there are other ways, dietary or non-dietary to meet your calcium needs.
Right. And I know for vitamin D, especially, we have to make the vitamin D in our skin by exposure to sun. So if you're not outside hardly at all, it's very likely that people are deficient in vitamin D. And that I know in other studies for the general public who are older adults, supplementing them with vitamin D really hasn't shown the benefit that we were hoping to in terms of, preventing fractures and whatnot. But I think certainly if your vitamin D is low, then repleting that is helpful for your bones.
Honestly, that generally feels like the story of like nutrients.
Everything.
Well, it's just you don't want to be low. It doesn't. You don't necessarily be super physiologic, but you just don't want to be low. And so, but to your point, depending. I mean, you do make vitamin D in your skin. It doesn't even take that much time, but I mean, I think it's like 15 minutes on your hands. It's not that much, but like certainly, I mean, depending on if you're able to go outside or where you live, how, how cloudy it is, time of year, that can certainly influence your body's ability to synthesize vitamin D.
Gotcha. All right. So to summarize the lessons that I think you taught us today for bone health, we know that weight loss oftentimes comes with bone loss, and that to prevent too much bone loss, we should be conscious of the type of exercise we do, do kinds that load our bones. So, a weighted vest or I wonder if rowing is something that can, I guess we move the muscle so that loads the bone.
Absolutely.
That's my preferred manner of exercise. And then, so exercise, not just getting your heart moving, but also loading your bones. And that pay attention to how much calcium, vitamin D, and protein you take during the day. And that some of these new drugs are just too early to tell in terms of whether they help or don't help in terms of bone. Anything else you want to add?
I think that maybe the only thing I was just thinking about, when people, we are concerned about bone, and the clinical endpoint of interest is fracture, so people tend to fracture when they fall. And so thinking about balance training, I think, is really important. And then the other thing maybe I would just circle back to when we were talking about osteoporosis, and like the DEXA scans are great, and that is clinically how we measure it. Sure, there is a movement in that field to recognize prior fractures as really important. It's not, if you've had a prior fragility fracture, like that probably would mean that you have osteoporosis, even, just because you've already had the endpoint, and certainly having had a fracture increases likelihood you have another one. So just something for people to be aware of, even if they haven't had a DEXA scan, that,
Right. Yeah. My mom's first diagnosis of osteoporosis was actually because she was texting on her phone while walking down the stairs and then slipped. And I think landed on her outstretched hand and then fractured her wrist.
Yes.
Or the forearm bone, I should say. It wasn't exactly the wrist, but it was the forearm. And so, from there, then it was, she had a DEXA scan and showed that she had weak bones, which was not surprising given her mother's history. So, yeah. Oh, well, thank you for joining us today,
Of course.
Kristen.
This was lovely. Thanks for having me, Mia.
Thank you.